Guys, this is Mobeen. Welcome to the webinar. This is about the ECG and the fundamentals of ECG. A little bit of the procedure about this webinar. We have Pankuri from MSAI India, who is helping me moderate this. I'm going to see if I can add her live here as well. So give me 1 second. Okay. So I may or may not be having her with me, but anyways, what you can do is you can connect with her on the Facebook. You can also connect with her using the WhatsApp. And if there are any questions, you can put them here on the live Hangout as well. In the future, we'll do Hangouts using other webinar software where you can actually directly speak with me. So today it is more of a monologue. I'll be speaking and you can write questions or you can write comments, or you can speak with Pankuri and she can reach out to me through the WhatsApp. However, the future webinars will be more interactive and less boring then. All right, so let's start. The topics that we'll cover today are going to be the number one. I'm just turning on the Q&A as well. So the topic that we'll cover today are number one, the ECG leads. And why is the ECG? What is the conduction system of the heart? How is the ECG or electrical currents produced and measured? Then ECG leads, then ECG paper, and finally the ECG waves and intervals and their significance. So we have a lots of ground to cover. Let's start. What I'll be doing is I'm going to start sharing my screen. So as I speak, you can see some of the drawings that I can do and discuss with you. So let's start. Okay, so hopefully you can see the screen here. I have a picture from Wikipedia. So disclaimer that the pictures are from Wikipedia, so thanks to them. Here's a picture of the ECG leads. What I'm going to do is I'm going to take this picture away and I'm going to start on an empty fresh layer, and let's start talking about the ECG. So first of all, consider this, and this is what I see students to be confused a lot. Consider this, that our body is actually a container of water, right? So this is a container of water. In this container sits the heart. So this is the heart. Now, because we are immersed, or the heart is immersed in water, and this water is rich in electrolytes, so it is a conduction or conducting medium. It is conducting medium. That is first thing to note. So there are some fundamental things I would like you to put them on a side or write them down so that it is easier for us to discuss them. So we have the conducting medium. This medium allows the electrical activity of the heart to become available in the other body tissues. So that is the first thing to note. Now, if I attach limbs to this body, then I attach a little head over here, I attach legs over here, then the electrical activity of the heart through the conduction mediums will be available in almost every part of the body. So that is one. Second, please realize, if I make this again over here, and here is the heart. So this is really important. Right above the heart. So I'm going to stop sharing the screen so I can point to myself. So right above the heart, if you put the probes, if you put the electrodes here, you can measure up to 110 millivolts of the current. So please write it down somewhere. Right above the heart, the current measurement can be up to 110 millivolts. As you start moving away from the heart, for example, let's say you go to the ends of the chest, the millivolt drop and you can measure up to 2 to 3 millivolts. This is the second point to note. And this is important. For example, I was in a clinic a few days back, and the doctor, a friend of mine, the nurse was having a problem getting the correct ECG signal. And what he did was he took the electrode off from the patient's wrist and put them here. And he said, well, sometimes you can get a stronger signal here. Yes, you can get a stronger signal here. Why? Right above the chest is 110 millivolts, and at the ends of the chest, you can get it about 2 to 3 millivolts. And if you keep going away from the body all the way to the wrist or to the foot, the millivolts will become about 1 millivolt. So this is one thing to keep in mind. So please write it down somewhere. 1 millivolt at the ends of the limbs. Second thing is, keep this in mind as well, that a normal healthy person, about 0.8 second of a heartbeat, which means that about 72 heartbeats in a minute. I have my calculator here as well, and I want to make sure that I have WhatsApp as well. All right, so keep these two things in mind. Third is, before we discuss more on the ECG and electrical activity, approaching the ECG, you have a rule of fours. So please write it down, the rule of fours. How do you approach it? Many times our basic problem is not that we don't know the knowledge. The problem is, how do we approach the ECG? So number one, first of all, is the context. Context means what is the situation. So in the context, you need to understand the history of the patient. Why did the patient come to you? What are the presenting complaints? So history is important. Then the patient's situation is important, and so on. So first is the context of the patient. Second is the four waves. What are those waves? We'll talk about them today. P, Q, R, S, T, and U. So four waves. Third is the four segments and intervals. So PR segment, PR interval, QRS, and ST and QT. So four segment and intervals. And fourth point is the diagnosis. So that is the rule of four. And how do you approach an ECG? Keep this in mind, and for an ECG, please write it down. First thing to detect as a doctor, as a health professional, as a student, first thing, you look at the ECG strip, and the first thing you want to detect is, what is the rate of the ECG? Rate. Second thing that you want to see, especially for the QRS and P waves, what is the regularity of these? Are they available in the ECG at the right time, and again, are they repeating or not? Third is, what is the waves sizes? Are they wide or they are narrow? Are they tall or they are short? And fourth is, what is their relationship to each other? Is the QRS complex, for example, coming after the P wave and coming at a regular interval after the P wave? Or P wave is going on its own and QRS complex is going on its own? Or sometimes QRS complex has just disappeared and sometimes it's present. So rate, regularity, the relationship, and then the waves, height, width, and finally the intervals. So this is how you approach it. So I'm going to go back to the screen and continue sharing the screen and continue with the lecture. Okay, so back here. So the first thing to understand now, after knowing that we have a medium in which the heart is present, and that is a conducting medium, the first thing after this to understand is that heart's electrical axis. So if I take a human being, so let's say this is a human being. Let's make one. Hold on. I need to create a layer here. Okay, so in this human, we will have a frontal section done. So frontal section, it is parallel to the frontal bone. So if I make a 3D diagram of the person, I think this is the most important concept to capture about the ECG, and many of the students miss this. So this is the frontal section will be that you have parallel to the frontal bone, you have a section from the body. So that means you remove a part of the chest and you directly look at the heart, and heart is sitting in here. So first thing here is that the electrical current, guys, pay attention to this. Total electrical current moves at a degree 59 degrees in the chest. This is the sum of current's electrical movement. Please keep this in mind. Why will this be important? Because number one, we will be able to understand the axis deviation if we understand the normal axis. And number two, we can now determine which lead will do what. What should you expect in a lead? Normally, students do not start from here that the normal axis is what. And they keep trying to cram various lead and say that, all right, this lead does this. So this is really magical. Once you understand that this is the electrical axis, look what happens is, I'm going to make the conduction system over here and show you how this electrical axis works. So we all know that heart is composed of two atrias. Then there is a fibrous ring which has AV canals in it, right? This fibrous ring is really important for medical student to know, this ring here. Why is that important? This is this fibrous ring that insulates atria from ventricles. But insulation, ventricle. Insulation, electrical insulation. That means when electrical activity generates in heart, atria, they contract as a unit, as a syncytium, electrical syncytium, and ventricles contract as a unit or electrical syncytium. But atria and ventricles should not contract as one unit. No. Why? Imagine this. Atria has the blood in them before the ventricles. Now they need to kick the blood in the ventricle before ventricle starts contracting, correct? What if they both started contracting together? They'll squeeze the blood back towards each other and nothing will happen. The heart will actually not pump anything out and we'll have a heart failure. So what you want is, you want the atria to contract first, push the blood in the ventricle, and then the ventricle have to contract. So there needs to be a delay. There needs to be a delay between the atria and ventricle. This is the most important concept in the ECG. There needs to be a delay between atria and ventricle, number one. Number two, there needs to be insulation. If this ring of insulation is not present, and in some patients, they may have a fiber that goes through the insulation and connects the atria and ventricular muscles, and they would have problems. I hope that you know that there is a Wolff-Parkinson's syndrome and so on. These are the result of insulation failure. If this insulation was not present, then both of the units, atria and ventricle, would try to contract as a unit, and that would fail the heart. However, when the insulation is present, then the heart would act correctly. All right, so keep that in mind. Now, let's continue our discussion of the conduction system. So if I now put the atrias here once again, this is the insulation, this is the ventricle. We know that SA node, which is the automatic tissue in the heart, this is the pacemaker of the heart, this is what generates the regular electrical activity in the heart. SA node is present near the opening of the superior vena cava, right? Electrical activity starts from here, and through three main bundles, it spreads in the atria. From there, it reaches the AV node, which is present in the right atria, in the lower part, near the lower oblique part of the sinus. But anyways, it is present near the septum, between the AV canal on the right side. So if this is the right AV canal, this is the septum. It is present between them. Then AV node gives off bundle of his, or AV bundle first, and then that converts into two separate pathways. And finally, what happens is these pathways become continuous with Purkinje fibers. And you know that Purkinje fibers are interesting, that they are embryologically, they are modified muscle. So this is where electrical system and muscle system start connecting together at the Purkinje fibers. However, what I want you to focus on is this area, this part of the conduction system. So after the annulus fibrous, or the fibrous ring for insulation, the second most important concept to keep in mind, so please write it down somewhere, the delay between atria and ventricular contraction occurs because of the delay that occurs at the AV junction. So electrical current comes up to the AV node, then it is asked, so when the electrical current reaches here, we ask it to stop here for a few milliseconds. And then it slowly moves out. And then once it reaches in the ventricle, it rapidly goes throughout the ventricle. So the question is, what causes this slowness? What makes it slow? So there are many theories. Basic theory is this, that the intercalated discs, you know that if I make heart cells are connected to each other like a syncytium, right? And they have intercalated discs. These intercalated discs allow the ions to flow from one cell to the next cell, right? So heart doesn't have the nerves that would go and supply every single cell. It is really one cell that gets the action potential and has ions. For example, sodium comes in, that sodium from that cell will leak into the next cell through the intercalated disc, or the junctions. These junctions are less in this area. In this area, they are less. So it takes longer from one cell to go to the next cell. Similarly, the calcium channels here and the other channels here are modified. They are slower. The end result is that the impulse takes some time to go from AV node and AV bundle to the ventricles. That time is useful to allow atria to contract and then give a gap, and then ventricles would contract. This is what we can actually find out on the ECG as well. Okay, so with this fundamental, I want to do one last concept here, and then we'll go and talk about the leads. I want to build this concept here, and I see the students struggling with the axis deviation. So look, guys, I'm going to make an X and Y axis, right? And let's make a vector here, just some line. So don't get terrified of the math of the ECG. It is actually very simple. So let's say this is a line. Keep in mind that the thing that is called projection of a vector, I'm writing here, projection. So please draw it somewhere on your paper as well. Projection of a vector means you drop a 90-degree line from the head of the vector onto the axis. So I'm going to drop that line. This is 90 degrees on x-axis, and this is 90 degrees on y-axis. Now here, if you draw one line from here to this intersection, and if you draw one line from 0 to this intersection, then these two vectors that I just made, these two lines that I just made, are the projections of, if this was line A or vector A, then this B is its projection on x-axis, and this C is its projection on y-axis. Why am I teaching you this? This is, hopefully this is simple, but why is this important? That as we see the electrical activity in the heart, you will have to project that activity on the leads. So before I go to the leads, let's do a small exercise. We are going to use projection. So let's say this is a heart, and the heart has electrical current that is going this way. This is the electrical current going at 59 degree. Now I'm going to make a lead, and I have not done the lead, so I understand that it is unfair of me to just make it here and say this is lead, but imagine for a second with me. I'm going to make lead 1 over here, which is usually horizontal lead. Now, can you make the projection of this vector on this lead? Yes. So what you do is you pick up the vector and you attach it to the lead. So I'm going to draw, for our purposes here, I'm just going to draw the lead here. As I draw the lead here, now this is the vector, drop a line like this, and I'm going to make it in blue. This line here is the projection of this red arrow onto this horizontal line. You can actually, I'm sure that in many of the countries where you're joining from, it is night over there. You may have a pen in your hand and you have a light somewhere in your room. So do me a favor, if you have this piece of paper and you have light somewhere, so let's say this is light. If you put your pen on the paper like this and observe the shadow, that shadow of the pen is the projection onto the paper. This is exactly what we have to do. And why is this important? ECG leads are nothing but projection of the heart activity onto that lead. So what does that mean then? What that means is, and I'm going to stop sharing the screen so I can see you and you can see me. What that means is you don't just have to remember that ECG lead 1 is right arm and left arm, and the negative goes in the right arm and the positive goes in the left arm. What you have to understand is that the lead 1 is a horizontal lead, and the heart electrical current goes in the heart like this. So if you put it on a horizontal line, you have to understand the projection that would tell you electrical amplitudes. How tall should be the QRS wave? How tall should be the P wave? How tall should be the T waves? You don't have to remember it once you understand the idea of the projection. So I would actually request you to pick up your pen and put it on a piece of paper, whatever piece of paper you have in front of you, and observe the shadow on the paper. That shadow is the projection of the pen, and try to change the angle of the pen. If it is like this, what happens to the shadow? If it is like this, what happens to the shadow? And that would tell you that when the current is moving through the heart and various leads are looking at that current from various angles, the projection is what is important. And you can actually figure out that projection while looking at the ECG. So back here, let us now, I think we are ready to look at the ECG leads. So look at this. Here are the leads. I have a very simple mnemonic for the leads, and that is wherever the word left will come. So let me just take this out. Wherever the word left will come, that word, let me add a, yeah, left should mean to you as positive. For example, right arm, does it have any word left in it? No. So it would have two leads, right arm, and they both are going to be negative. Left leg, left leg, does it have two L's in it? Yes. So it is going to have two positives on it. Left arm, does it have two L's? No. Does it have one L? Yes. So it is going to have one positive on it. What does this mean? So let me explain. What happens is the lead 1 is a lead that goes from right arm, that is attached to the right arm and to the left arm. What does that mean? We have a voltmeter or the ECG machine here. The ECG machine has a negative terminal and a positive terminal. The negative terminal is connected to the right arm and the positive terminal is connected to the left arm. Now we also know that when current, positive current or depolarization moves from negative towards positive, then it creates a positive deflection on the voltmeter. And if you don't know that's a very basic idea. Please let Pankhuri know, and we'll do a separate lecture which will actually go in the conduction system basics or fundamentals, and we can do the channels and the voltmeter and why does it read positive or negative. I want to go into the ECG and start getting you able to start reading or approaching the ECG. So I'm deliberately not touching those pieces. Okay, so here the positive is on the left arm and negative is on the right arm. So when the current will move this way, and if you put the projection of this, remember now we are talking about projection. If you put the projection of this onto the, I'm just going to make it a little bigger so we can all see it together. Give me 1 second. Okay, anyways. All right, so the projection, I wanted to have a bigger picture, but apparently I can't. The projection on the lead is the vector that is going to show up as positive deflection. So that is one. If somehow, let's say the patient has an axis deviation, the heart had moved in a way that the current went this way, then the projection is going to be this way. The depolarization going towards the negative. When the depolarization goes towards negative, then the lead will show a negative deflection, and that would mean the same lead should register a QRS complex like this. Right? So projection of a vector is really important for you to understand. And as soon as you look at an ECG, I'll show you. So let's look at one ECG very quickly. As soon as you look at an ECG, this is the give me 1 second. Here is an ECG. So when you look at an ECG, what you have to do is immediately look at what lead should have the tallest upward deflection. Normally lead 2 should have, and I would explain that in a second, but also look at other leads. Look at lead 1. The QRS complex here is tall, but it is almost half above and half below. In lead 3, the QRS complex is all upwards as well. Let's look at this. Look at this AVL. QRS complex is mostly going downwards. Look at the V1, almost half above and half below. So this should mean something to you. And that is what I'm trying to explain now. So let's go back to that explanation. So what happens is that as the current moves in the leads, the projection determines if you would see a positive or a negative deflection. So please write it down somewhere on a piece of paper that when the depolarization moves from negative towards positive, then you have a positive deflection. That is one rule. That also means when depolarization moves from positive towards negative, then you will have a negative deflection. That also means when repolarization moves, so I'm going to reverse this now. When repolarization moves from negative towards positive, then you have a negative deflection. And when repolarization moves from positive towards negative, then you have a positive deflection. This will be handy because we are going to explain why the P wave is positive. Look, P wave is a ventricular repolarization. Ideally, it should be opposite of the ventricular depolarization. However, it is not. And we'll explain that today based on this rule. So put this rule somewhere on a piece of paper as well. Okay, so lead one now, going back to the leads. I'm going to remove this. Going back to the lead, lead one is right arm and left arm. It is looking at the heart at the 0 degrees. So if the electrical current of the heart is 59 degrees, lead one is oriented from 0 to 180 degrees, so horizontally. So that is lead one. Let's look at the lead two. Lead two over here, this is the most important lead. Why is this the most important lead? Because this lead in a healthy normal individual is the most closest to the angle of the heart or axis of the heart. It goes from the right arm, that would be negative. Right arm cannot have a positive because it has no L in its name, to the left leg. And left leg has two L's, so both leads here attached are going to be positive. So positive means now if the heart has electrical current that moves like this, isn't that if you project that current onto this lead, that is parallel. And a lead that is parallel to the electrical current would have the maximum deflection. So that is why, you know, the lead two, the axis of the lead two is usually 60 degrees. Heart's axis normal is 59 degrees, so almost 100%. So when you look at the lead two and you look at the current in the lead two, that current should show you 100% of the amplitude of electrical activity. So here, if you see this lead, give me 1 second. If you see this lead two, this lead two, this amplitude is actually 100% representative of the electrical activity. And look at this, it is positive upward deflection. So that means the heart's axis is the same as the lead two's axis. And what is the lead two's axis? 60. So that means heart axis is also 60. It should be 59. This person has a normal cardiac axis. If, for example, lead two had QRS complex that looked like this, don't go for the wider one, that is just my drawing problem. But if you see, half of the QRS complex is above and the other half is below. What that means is, let me go back to the, what that means is, I'm going to be here, if QRS complex in a lead is equally present above and below, that means that if the lead is this way, then the electrical current is traveling at 90 degrees to it. So if lead two, so guys, listen to this one, please. This is very important. If lead two show you a QRS complex that looks like this, and I know that we have not talked about the QRS complex, so I'm going to go back and talk about that in a second, but just keep this in mind from lead's point of view. If lead two has a QRS complex that is like this, that means heart's axis is at 90 degrees to the lead two. And what is lead two's axis? 60 degrees. That means 90 degrees of axis here is either 120 or minus 30. This heart is deviated. We don't know it is deviated towards the right or left, but we know this heart is deviated. So we need more leads to figure out where the heart's axis is. But this patient is your patient. You need to figure it out what is going on. This is why it is really important to have the idea of the projection. So let's go back to that ECG for a second. So once again, in this patient, or this person is not a patient, his ECG is at least normal. In this patient, his QRS complex in lead two is looking good. Is there any lead here? Can you detect where the QRS complex is half above and half below? Yes, I can actually see that in AVL, and I can also see that in V1. I can also see that in V3, which should tell you that the electrical activity of the heart is 90 degrees to the leads orientation. Okay, so if we know that, then here is the difficult part. Shouldn't you then know what leads orientations are? Yes, that is why we are doing leads. So lead 3 here is from left arm to the left leg. And positive, remember left leg has two L's in it, so both positives. And left arm only has one L in it, so one positive lead and one negative is attached here. So lead 1 is positive for the left arm and lead 3 is negative for the left arm. Now let's continue drawing them in a circle as well. So lead 1 was looking at the heart at a horizontal axis, 0 degrees to 180. Lead 2 is looking at the heart at 60 degrees angle, which is also the angle of the heart, so it should have maximum amplitude. Lead 3 is looking at the heart at about 120 degrees, almost reverse or almost the same as the lead 2. One is on the right side, that is 2, and the other one is on the left side, but they both are looking at the heart almost on the same angle. And so they both should show similar amplitude, similar QRS complex, and similar size. So let's go check that. Look at this. Lead 2 and lead 3. Aren't they almost identical? Yes. And why are they identical? Because they both are looking at the heart at the same angle. It's just that one is looking from the left side and the other one is looking from the right side. Okay, going back to our discussion. How about augmented leads? So let's talk about the augmented leads for a second. And I've seen students getting so much confused with the augmented leads and what the heck are these? Look, augmented leads are a simple phenomena. I'm going to make this a little smaller and away so we can discuss this here. Look, here's the deal. This is the body, and we have lead 1 attached like this, lead 2 attached like this, and lead 3 attached like this, right? There is some amplitude, there is some electrical potential in these leads. One of the doctors said, who was mathematician as well, unfortunately better than us, unfortunately for us, we should be mathematician too. So what he did was, he said, look, if you pick up the potentials of all of these leads, lead 1, 2, and 3, and mathematically average them, so that would mean take the potential of lead 1 plus take the potential of minus of the lead 2 because the angle, and then they take the potential of lead 3 and then divide them by 3. That would give you the average. If you take that average potential, that average potential is somewhere between the pubis and the belly button. So somewhere over here. It's called Wilson's. This was Dr. Wilson. It's called Wilson's point. So that guy said, Dr. Wilson said that, so let me just quickly make the human here. He said, if you take a mathematical average of the leads, then what you can do is you can also take the same leads again, that is lead 1, 2, and 3, and use this mathematical Wilson's point as a negative lead, and you can create an augmented voltage lead. What does that mean? It's still interesting to see. So let's see what that means. What that means is, if you take the lead that is coming from the left leg, remember left leg is connected to the ECG machine for lead 2 and lead 3. So there is a connection from the left leg. If you use that positive, and then for the negative, instead of using right arm or left arm, instead of doing that, for the negative, if you use this average, then you have abstractly, you have virtually, you have faked, you have mathematically created a lead that has positive on the foot and negative almost above the pubic area. So this is that lead. It's a virtual lead. It's an augmented lead. That's why it is also called unipolar. It is actually really not unipolar. It has bipoles. All leads have bipole. The only thing is its negative pole is a mathematically calculated pole instead of a physical lead. However, its positive pole is a physical lead that is attached to the ECG machine. So now you say, what the heck? What is the benefit of this? Look, what we are trying to do is this. Let me start looking at you for a second. What we are trying to do, look, there is a camera right there that is looking at me, right? And if I turn, it is going to look at me, and now it has a different angle of me. It is the same me. If I turn the other way, it is still the same Mobeen, but you're seeing that my features are becoming different as you see, correct? We want to see cardiac action potential, the heart's electrical activity. We want to see it from many angles. Imagine if every lead is a camera. We want to attach so many cameras that we can see electrical activity from every side, and we can see if there is a ischemic attack here, or if there is infarction over there, or if there is a bundle branch block, or there is a hypertrophy. We can detect that. So we want to attach more and more cameras. So Dr. Wilson said that instead of adding more leads to create more cameras, why not we mathematically create leads? So that was his contribution, that he gave a mathematical formula, simple formula, that allowed us to use the same 3 leads, limb leads, and then do the mathematics on them to create 3 more virtual leads or augmented leads. Now, if you see, if you come back here on the drawing board, by the way, I love ECG. So come back here to the drawing board, and what we'll do is this. Let's move that here. And let's draw what does that mean to us. Look here, I really like this diagram. This is my way of understanding it. So let's say this is a a cup in which one can have a smoothie or a wine or a beer or a simple by the way, I don't drink, but anything. It's a cup in which there could be some. So in our case, in here sits a heart. Ladies and gentlemen, I have a heart in this little cup. And so don't start giving the gift of heart in these cups, but this is a heart sitting in here. What we are trying to do is we are trying to look at heart from various angles. So look, this angle is lead 1. It is looking at heart. Then this is lead 2. It is looking at heart from right side towards it. Lead 3 looking at the heart from left side. Then AVF, that is the augmented lead attached to the foot, F for the foot, is looking up. So if you wanted to see if there is an ischemic attack or there is an infarction on the inferior surface of the heart, guys, I've seen students cramming it, inferior surface lead, this, and this. No, look at this. Lead 2 is looking at it from the inferior side. Lead 3 is looking at it from the inferior side. And AVF, just remember this little cup with the heart in it. That is the benefit of the AVF. Similarly, the doctor said, that Dr. Wilson, that if you take the AVL, that is the left arm, and then the same Wilson's area here, then you create another lead that is looking at heart from here. So what is it looking at? It is left lateral side. So now how many leads are looking at the heart from the left side? Lead 1 is looking, positive is the looking side. So lead 1's positive is on the left side, right? So lead 1 is looking in from the left. Lead 3 almost is looking in from the left, but really that is inferior. So left lateral AVL, L for the left, that is looking in from the left. How about right side? Is lead 1 looking in from the right? No. But because looking in, lead 1 is looking in from the left, if you reverse the action potential of the lead 1, in your mind, if you look at the lead 1 and just inverse it, that would be the action potential on the left side. However, there is an AVR. What is AVR? AVR is you take the right arm's lead and the Wilson's potential, mid potential as negative, that creates a lead that looks at the heart from the right side. So there is a camera. I'm going to try to make a camera now. This is a stupid camera, but let's make it. This is the camera. So there is a camera that is looking at the heart from the right side. There is a camera that is looking at the heart from the left side. Right? Keep this image in mind. I'm going to show myself for a second. Keep this image right and left, AVL and AVR. So now, so this is my right. I don't know if when you are looking at me, this may be looking at left. This is my right. So AVR is looking down at heart from the right. So there is a camera attached here. This is my left. And the AVL is looking at heart from the left. There is a camera attached here. So here is the deal. Whenever you look at the ECGs and the leads that represent various parts of the heart, you will very rarely see AVR used. Poor AVR. AVR is called as a lone lead. AVR is also called as forgotten lead. Why? Simple. I know that many of you know the answer, and you may have been writing it, or you may have been, unfortunately, you cannot talk with me. From next webinar on, we'll have a software that would allow you to talk with me. So you can just respond right there. So anyways, the right AVR is forgotten or lone or not needed because it is the reverse of AVL. So whatever you see in the AVL is what you, inverse of that is in the AVR. So if you have AVL, you don't need AVR. Or I can say if you have AVR, then you don't need AVL. However, because we are more concerned for the left side of the heart, why? Because the left ventricle is there and most common problems occur with the left ventricle, we are more curious to keep the left side leads intact. Got it? So coming back here to the drawing board, coming back here, AVR, although present, is usually not seen. So I'm going to show you what lead shows what, and you would see that AVR has, so here, look at this, lead 2 here, lead 3, and AVF. Remember that little cup? Can I make that cup appear here as well? Oh wow, that's a large cup. Okay, so let me move this lead table over here. This table is also from Wikipedia, so it's not mine. And it's thanks to Wikipedia. So look at this. Inferior surface of the heart, lead 2, right? So you can see lead 2 is looking at the heart from here. Lead 3 is looking at the heart from inferior, and AVF, lead foot. So please don't cram this table. It is simple. Just draw this cup and the heart in it, and you're presenting the heart. Why do I make a cup? Because we have to put the chest leads as well, and this cup is excellent to put the chest leads on it. How about the lateral side, the left side? AVL, as we said, and lead 1, as we said. Remember we said that lead 1 is looking in from the left. So AVL and lead 1. How about chest leads? We have not done the chest leads yet, but 5, 6 chest leads would also see from the left lateral side. How about the anterior side? Again, chest leads, so we've not done them, septal side chest. But look at this poor AVR here, this pink AVR. It is just sitting there doing nothing because AVR is represented with AVL inversed. Okay, cool. So we've gotten the idea of the lead. So although we say 12 lead ECG, I want you to understand that basically there are, how many leads are actually attached? There are 3 leads attached to the arms or limbs, actually 4. There may be an earth attached to the right leg, And then there are 6 leads attached to the chest. So basically you may have 9 or 10 leads. So physically you don't have 12 leads. However, we call it 12 leads because 3 of them are augmented leads and are calculated. So let me go to the leads. Give me 1 second. I'm going to bring in the leads here. So once again now, in this lead, these 3 leads down here are calculated leads. They are not physically present. They use the same leads as the limb leads. So we're good. Now let's talk about the chest leads. Chest leads are simple and easy. The concept that we need to understand is this. The concept to understand is this. Let's say this is the chest of a patient, and this is the heart sitting in it. So we have figured out a way to look at the heart in a frontal plane, right? How do we look at a heart from another plane? So normally we have 3 dimensions, right? We have x-axis, we have y-axis, and we have z-axis. So we have been able to look at the heart through the lead 1, 2, 3, and AVL, AVR, and AVF in the frontal plane. But we want to look at the heart in the coronal plane as well. So sorry, not coronal. What should be that plane? Horizontal plane. This plane. This plane. So we want to see the heart from front as well. We want to see the heart from side as well at a different plane, at a horizontal plane. So chest leads allow us, and I'm going to show myself to make a gesture on myself. So chest leads, with the leads 1, 2, and 3 and augmented leads, we are able to see heart in the frontal plane. Now we want to see the heart in this horizontal plane as well. And for that, you put the chest leads. So that gives us 2-dimensional picture of the heart. Now, what are the chest leads? Really, these are very, very simple. Chest leads there are 6 leads. How do you place them? First of all, V1, and I'm going to go back to the drawing board as well to kind of show you what this would represent. Okay. Okay, so the chest lead, look, I'm going to cut the patient horizontally in the horizontal section, put the heart in the chest cavity and cut it. The heart in the chest cavity looks like this. Right under the sternum sits the anterior right ventricle, then part of the left ventricle, and most importantly, the septum, interventricular septum. So interventricular septum and the right ventricle anterior surface sits right below the sternum. Left ventricle, a little bit of that is also present there. So if this was a sternum, you put a lead here, you put a camera here that looks down, and a camera here that looks down. What is it going to see? It is going to see the anterior surface of, so V1 is this one. When it is sitting on the right side and looking down in the chest, it is looking at the interior surface of the right ventricle. And if you go a little deeper, it is looking at what? It is looking at the interventricular septum. So interventricular septum sits like this. This is the left ventricle, and the right ventricle I've removed. That would be here. So if you go deeper, you are looking at the interventricular septum. Now V2 is on the right side of the, on the left side of the sternum, 4th intercostal place, and that is also looking down, just like V1, and it is also looking at the anterior surface of the heart, which is in the chest. It is the right ventricle plus the septum. That is why V1 and 2 are called septal leads. Now, the placement of these leads is that the placement of these leads is go to the on the right side. V1 is going to be fourth intercostal space right to the right border of the sternum. V2 is on the left border of the sternum, same intercostal space, fourth intercostal space. Then you do not put the lead for the V3. Instead, you go for the V4 first. V4 is mid-clavicular line in the fifth intercostal space. And in the women, there may be breast tissue, so you move the breast so much so that you could go as close to the fifth intercostal as you can. Some obese men would have the same problem as well. So just try to be as close to the fifth intercostal in the mid-clavicular as you can. Once you have the 4 attached, then the 3 is going to be between the 2 and 4. If you make a line, just put 3 in the middle. So that becomes third. Now sixth, and sixth, I put 6 first. 6 is the mid-axillary line. So you go to the axilla middle and you drop a line, fifth intercostal space. That is where the 6th go. And where does the 5th go? 5th will go basically between the 4th and 6th, but it can also be the anterior axillary fold. If you drop that down on the 5th intercostal space, that is where the 5th go. Now, how are they looking at the heart? Let's look at this. These leads are looking at the heart. 1 and 2 are looking at anteroseptal. So if you suspect that the patient has some problem going on with the septum or with the right heart, then you look at lead 1 and 2. Lead 3 and 4 will look at the anterior surface of left ventricle. So almost anterior, but left anterior. So that is really important. 3 and 4 are going to tell you what's happening with the ventricle. And 5 and 6 are purely looking at the ventricle from the left side. So that means you have to always quickly look at V1, 2, 3, 4, 5, 6 to see what's going on, or if there is anything going on with the heart. So let's look at this ECG. This is V1, 2, 3, 4, 5, and 6. V1. What is the QRS complex like here? V2, this is so they both are looking at the heart from the anterior and septal part. V3 is looking at the heart slightly on the left lateral. V4 similarly left ventral. So V3 and 4 should be similar. V5 and 6 are looking at it purely from the left side. So that is the leads. Now let's talk about waves of the ECG and their interpretation. How does that happen? Let me just set up my... So here, I'm going to move this picture over here, and let's start with the waves. Look, I'm going to make heart SA node, subtrad AV node, bundle of his, then bundle branches, and Purkinje, right? So that is the anatomy. First of all, the structure of an ECG is that we have P wave, then we have QRS complex, and then which is actually QRS complex is an interval. Then we have T wave and we have U wave. P, Q is not always present, QRS, T, and U. This is the basic structure of the ECG. Couple of things here. First of all, intervals. Look, intervals has the word V in it, which is almost sounding like W. So whenever you have W for interval and W for wave. An interval is defined as an area of the ECG that has an isoelectric part and a wave, one or more waves. Interval must have a wave because it has a V in it, V for wave. Segment does not have a wave in it. It is part of the ECG that is isoelectric. For example, here, this line is isoelectric. So this may be a segment. This line is isoelectric. So this is a segment. Segment doesn't have anything that sounds like a wave. So it does not have a wave in it. Got it? So for example, PR interval. Interval has a V in it. So there should be a wave. So starting off the P to the beginning of the Q or beginning of the R is a PR interval. However, PR segment will be, it should not have a wave in it. So end of P wave and beginning of R. So let's go back and see how these waves are produced. Waves are P, Q, R, S, and T, U. P wave is atrial depolarization. So when the SA node produces the electrical activity, look at this, that positive end, we're talking about lead 2, that is the most in line. Positive end is here, negative end is here. Electrical activity starts from the SA node and moves down towards the AV node. So its axis is the same as the axis of the lead 2. So what do you think lead 2 would show? Lead 2 would show a positive deflection. Now, when the whole atria become fully depolarized, then the deflection will go back to the isoelectric line. The rule is that if both electrical probes are on the same electrical potential, either both negative or both positive, then the line shown is isoelectric. They only show a deflection when one is positive and the other one is negative. So this would show a deflection. And then similarly, if this is positive and this is negative, then this would show a deflection. So as soon as the whole atria becomes depolarized, that would mean the whole thing, the electrical probes are now sitting on depolarized potential, and so the wave will come back to 0. So P wave actually has two pieces to it. One is the upward deflection and then going back. Upward deflection is when depolarization is occurring, and going back is when depolarization has occurred. What is the size of the P wave? Normally, so the rule is very simple. Let me tell you a trick. Most of the waves are about 2 boxes. P wave is about 2 boxes. And we would talk about boxes in a second on ECG paper. The PR segment is about 2 boxes. QRS complex is about 2 boxes. And then T wave is 3 to 4 boxes. So let's call it 4 boxes for the time being. And the only thing that is odd is the ST segment. That usually is about 5 boxes. So if you just remember 2, that makes it very easy. P 2 boxes, PR segment 2 boxes, QRS complex 2 boxes, T 4 boxes, and the ST is 5 boxes. That's simple. Okay, so we got the P wave. Now atria are depolarized, and then the wave got stuck at the AV node. Wave is not moving from the AV node to the ventricle yet. Why? Because there is a delay. That delay causes an isoelectric line to continue. Then, look, I'm not going to make the normal ECG. Imagine if there is no ventricle. Then what happens is atria repolarize. So one question for you. What is the repolarization? Is it going to be the same direction as the depolarization or not? So repolarizing. So let's say this is heart. The depolarization started from here and went down here. So this cell became depolarized first. This cell became depolarized later. What do you think, which cell will become repolarized first? This cell or this cell? I hope you said this cell, because the cell that become depolarized first will finish the depolarization and will start repolarizing first. While this was repolarizing, this cell is depolarizing. So normally what you would say is, you'll say when atria depolarizes from above downwards, then the repolarization is the same way. What about the electrical activity then? So let's look at that. I think this is a very critical point. So what happens is, if atria depolarization goes from, let's say, negative towards positive this way, and that shows a positive deflection. And the repolarization goes from negative towards positive. Repolarization, that should show a downward deflection, right? We did that rule before. Depolarization, moving from minus to positive, shows an upward deflection or positive deflection. Repolarization, moving from negative to positive, would show a downward deflection. This is atrial T wave, which we normally do not see. Why don't we see it? Because QRS complex comes on top of it. And the electrical activity of ventricle is so strong that we actually are not able to see the atrial T wave. However, if there was no ventricle and there was no ventricular activity, you would actually see an atrial T wave where QRS complex is present. Cool? So atrial activity done. P wave represents the depolarization. P2R represents, this segment represents the time when atria is depolarized and impulse is stuck at the AV node. So if there is a problem with the AV node, there is ischemia of the AV node, then this PR segment will become longer. It's very simple. There's no magic here. Okay. T wave is not shown. Atrial T wave of repolarization is normally not shown because the QRS complex is superimposed on it and it obliterates this. Got it. Okay. Now let's continue. Impulse now travels from the SA node, reaches to the interventricular septum. When it reaches there, guys, what happens is that left side of the interventricular septum is stronger, plus left bundle branch is faster. It is bigger. So what happens is left side becomes depolarized first and right side is not yet depolarized. So it looks like, please pay attention to this, it looks like that electrical current is actually moving from the left to the right, like this. So that actually creates, look, this is the axis of the lead 2. This is the direction of the lead 2. And now our little current is moving almost in the opposite direction. Not fully in the opposite, but a little bit in the opposite. So that would create a downward deflection. That is the Q wave. Q wave is septal depolarization. Now, would it always show? No, not necessarily. It is not so strong in all cases that you would see it. So lead 2 would have it, then fine, it would be downward. If it doesn't have it, then so be it. And again, going down, so if I make the Q wave here for a second, when the activity, electrical activity moves from the left side towards the right side of the septum, then a downward deflection will be seen. When the whole septum becomes depolarized, then will become isoelectric again and the wave will come back. Now, as soon as the whole septum becomes depolarized, left side will start becoming, or the ventricles would start becoming depolarized as well. Now that, because left is stronger than the right side, the overall axis, so look, there is electrical activity going this way, this way, this way, and up here towards negative. But negative is bulky, it has gotten a bigger mass, so the overall size of the electrical activity is much bigger here. So you would see a positive deflection upward. Upward deflection means depolarization of ventricle, especially left ventricle, is happening. As soon as you reach the top, then the whole thing is depolarized, and what are you going to do? You're going to come back. Whenever electrical activity becomes uniform, then you come back. And finally, you would see a small S wave. What is that S wave for? That is the last part of the ventricle or the base of the heart becoming depolarized. That would create a small S wave. And then now the whole ventricle is depolarized. And when it is depolarized, we are on the isoelectric line. This isoelectric line would continue till the heart or the ventricle stays depolarized and contracted. If you have the muscle contraction superimposed on this one, at this time, muscle is contracted. And then the repolarization would occur. So here is the big deal. Ideally, we saw that the atrial repolarization was a negative wave. And we established I'm going to delete a little bit here on the ventricle. Guys, this is a good question for you. So let's see what your answer is. We have established that repolarization starts from the same point where the depolarization started, right? So, and that shows a negative deflection on the ECG. So one ventricular depolarization would start from here and move toward in the same direction as the repolarization would start from here and move in the same direction as depolarization. Should we not get a negative T wave like this, just like atrial negative T wave? Why is the T wave positive? Can anyone tell me that? Okay, so let me answer that question. I'm sure many of you know it. So here is why the T wave is positive instead of negative. There are multiple theories. One of the theory is that epicardium of the heart, the outer surface of the heart, gets the blood supply. Remember, the blood supply of the heart is superficial first. So because epicardium gets the blood supply more than the endocardiums, and endocardium during the squeeze, during the contraction of the heart is also squeezing, so there is less blood supply anyways, it is easier for the outer layer to start depolarizing earlier because they have lots of nutrition and blood supply available. That may be one reason. Another reason may be that the inside of the heart is totally, I'm going to overuse the term here or incorrectly use it is ischemic. Why? Do me a favor right now, clench your fist, make a fist and really make it hard, and then open it quickly and look at your palm. You would see that the blood in the palm has drained. So imagine that when heart is squeezing, inside layer has become clenched and it has become bloodless for a few seconds or few milliseconds. I shouldn't call bloodless, but very less blood. That also allows that inner layer not to depolarize fast. So the end result is that the repolarization goes opposite to the depolarization of the ventricles. That is the only odd electrical behavior in the heart. And because of that, remember we did that in the rules in the beginning, that when repolarization goes from positive towards negative, then it would show a positive deflection. That is why ventricular repolarization, the T wave, is actually positive. And finally, there is a U wave. U wave, again, we have no idea where the U wave comes from. There are various theories. I'll just put those theories in front of you as well. Some people say that the U wave comes or is produced because of the, so heart can be divided into three muscle layers, ventricles: epicardium or outer muscle layer, endocardium and the inner muscle layer, and then a sandwiched muscle layer between them. My phone would act as that sandwich, as the M cells, middle cells. Some people feel that outside becomes depolarized first, inside becomes depolarized last, middle becomes depolarized even later because it is totally sandwiched between outside and inside and has no chance of becoming depolarized fast. So maybe it is the repolarization of the middle layer, muscular layer of the ventricles that causes the U wave. That is one theory. Another theory is when the heart has finished the repolarization and it starts expanding, there is turbulence in the heart walls because the blood starts falling in. That turbulence causes electrical current, erratic electrical current, and that creates U wave. And then there are other theories as well. So not really important, so ignore that here. Now we've gotten the waves. Let's quickly talk about how much we should expect from these waves and intervals and segments. So I'm going to go back to the drawing board and show you these segments. Okay, guys, so let's see here. First of all, First of all, now we're going to start measuring. We're talking about the paper now. So before we measuring, let's just look at the paper. That would give us a better chance. ECG paper is made up of, and this diagram is from Wikipedia as well, ECG paper is made up of big boxes. Here is one big box and small boxes. Every big box has 5 small boxes in it. This paper rolls in the ECG at the rate of 5 big boxes per second. 5 boxes per second. So in 1 second, you get 5, 1, 2, 3, 4, 5. This represents 1 second. So there are 60 seconds in a minute. So 60 multiplied by 5, how many big boxes in a minute? 300 big boxes. Please write it down somewhere because we're going to use it now. 300 big boxes in a second. Every big box has then 5 small boxes in it. So how many small boxes in 300 big boxes? 300 multiplied by 5 is 1500 small boxes. Small boxes. Now, if 1 second is represented by 5 boxes, then what do you think? Each big box would represent what? It would represent 0.2 millisecond, or 20% of a second, or 200 milliseconds. We're talking horizontal. Horizontal is time, and vertical is voltage. Vertical is voltage, horizontal is time. Now, if one big box is 0.2 millisecond, and if you divide that into 4 pieces, then every small box is going to be 0.04 seconds or 0.4 milliseconds, whichever way you like. That is the horizontal side. Why is that interesting? I'll show you that in a second when we do the rhythm. On the vertical side, each one big box, it's relatively easy. One big box represents 0.5 millivolts. Remember, I talked about it in the beginning that at the end of the limbs, the voltage will be somewhere about 1 millivolt. So that will mean 0.5 and 0.5. If you have the probe attached to the end of the leads, then end of the limbs, then the QRS complex normally would be about 0.5 to 1 or even more millivolts. It may be as high as 2 big boxes. So upward small box is very simple. It is actually 1 millivolt. Sorry, 0.5, 0.1 millivolt. So that is the horizontal and vertical divisions. Now let us look at the ECG. So here is an ECG. Let's look at it. First thing, as I said in the beginning, to read the ECG, we need to understand what is the rate of the ECG. Rate of the ECG is actually very simple. Normally, ECGs have a lead at the lower part here, which is called rhythm lead, and it shows, it just takes lead 2 and just continues to make that rhythm. This particular ECG that I have over here does not have the rhythm lead in it. So now we have to calculate the rhythm. So there are a couple of formulas that are very simple and logical. One is count the big boxes between the 2 QRS complexes, or this is the RR interval, and divide 300 with this interval, RR. And we have to do the intervals yet. I want to just start with the rhythm so we can go back and look at the intervals and see any abnormalities there. So here in this ECG, let's read it together. What is the rhythm of this ECG? Two formulas we'll apply to get it done. Let's use a relatively less sophisticated formula, and that is count the big boxes. So one big box, 2, 3, 4, almost 4.5. Is there some other lead where I can go from boundary to boundary? I always like to go from boundary to boundary. This one, almost. So 1, 2, 3, 4. So about 4. So look, one big box. There are how many big boxes in a second? 300. So if you see one QRS complex in every big box, then how many big boxes in 1 minute? 300. And every QRS complex represents one heartbeat. So what would be the rhythm? 300. So if there is one QRS complex per big box, then you have the rhythm of 300. And how do you get it? 300 divided by number of QRS complexes in the big box is 1 is 300. How about this? If we have, sorry, back here, if we have, give me 1 second, back here. So if we have a QRS complex after 2 big boxes, what does that mean? What is that rhythm? So that means we would have, if there are 300 big boxes and we have one QRS complex after 2, then do this, 300 divided by 2 is 150. And so on. If you have a QRS complex after every third, 1, 2, 3, 1, 2, 3, then divide 300 by 3 is 100, right? So that is the rhythm. Another way to do that, which we will do it right now, is actually a little more accurate way, and that is to count the small boxes and then divide 1500, which is the number of boxes in 1 minute, by that number. So let's count the small boxes. We have one big box here that makes 5 small boxes. Another big box here makes small boxes 5. One more big box 5. One more big box 5. So we've gotten 20 for sure. Then this is one small box and this is another. So 22. And here is one more small box, so 23. So we've gotten 23 small boxes. If we divide 1500 by 23, let's see what that gives us. 1500 divided by 23 is 65. So this guy's rhythm is somewhere about 65. Cool. So now we know the rhythm this person has. Let's go back and look at the intervals. And actually, let's look at this guy. Let's continue analyzing this guy. Let's look at his P wave. This is the P wave. I'm going to make it a little bigger so you can see it. Okay, so this guy has a P wave here, almost here to here. Can you see this is almost 2 small boxes? P waves are usually 2 small boxes, as I said. P wave 2 small boxes, PR interval 2 small boxes, QRS complex 2 small boxes. So 2 small boxes mean 0.8 or 80 milliseconds duration. Then PR interval, do you see that this is also 2 small boxes? So another 80 millisecond. It can be from 80 to 1.2 milliseconds. Sorry, 1.2, yeah, 1.2 milliseconds. Then is the QRS complex. Let's calculate that. Q wave almost starts from here, 1, 2, and almost 3, 2 to 3. So it is from 80 to 1.2 as well. So this all looks good to me. And how about the PR interval? PR interval, look, it has the word V in it, which is for wave. So that would be beginning. I'm going to remove this. Beginning of the P wave, almost here, to the beginning of the R. If there is a Q, then beginning of the Q. So 2, 3, and 4. So PR interval is 4, which is fine. It can be 4 to 5. It can become broader. Why would it become broader? It can become broad when there is in conduction problem from the atria to the ventricle, when the impulse is taking more time at the AV bundle. Maybe that is an ischemia, or maybe there is a heart block happening. Okay, let's continue. QRS complex, we just saw about 2 small boxes. So it is usually from 70 milliseconds to 120 milliseconds. So 2 to 3 small boxes. If it becomes smaller than that, then we have a tachycardia for some reason. And if it is becoming greater than that, then we have a problem with the conduction. Okay, then let's look at T wave here. This T wave is usually measured in this way. If this is the T wave, what you do is you put a line like this on the slopes of the T wave, and wherever they interact with the paper, that is where you put the line and measure. So if I put a line here, this is one interaction, and if I put a line here, this is another interaction. So now let's look at the boxes in here. 1, 2, 3, almost 3.5. So T waves are usually about 4 small boxes. That will mean what? 4 small boxes would mean 160 milliseconds. Now, interval between the S and T, that is the ST segment. Look, it is an isoelectric line. So it would be a segment. It is not an interval. If we talk about the ST interval, that would be beginning of Q and end of T. Because it is interval, it must have a wave. This interval has 2 waves in it. ST segment, how many boxes here? 1, 2, 3, 4. So about 4 to 5 boxes. So 160 to 200 milliseconds. So what do you think the total time of depolarization for the heart, for the ventricles? 2 boxes here, 5 boxes here, 4 boxes here. So 160 plus 200 plus 80. How much did that come to be? Let's do that calculation. 80 plus 160 plus 200 is about 440. So this is actually normal. Somewhere about 380 to 440 is fine. Then it can become wider. If it becomes wider, we may have hypertrophy, or we have, problem with the conduction. It can become narrow, and that can be normal because a person has maybe doing exercise or some other reason for tachycardia. Cool. So this is the intervals. Now let's talk about the amplitude. I'm going to talk about the amplitude on lead 2. So before the amplitude, what you need to figure out is J point. J point is your friend. You need to know the J point. J point is usually where the QRS complex finishes and the isoelectric line starts. That is the J point. This is the J point. This is the J point. What is the J point? J point is supposed to be your normal or the baseline electrical potential. This is your 0 point. Now, when you count the QRS complex height, you have to count it from the J point. You can't just go and say, okay, I'll count here. This is the height. No, this is your J point. So from the J point, you go up and count them, and you go down and count them, and then sum them, and that is your total height. So let's look at the 2, so it is easier for us. Here is a J point. I'm going to ignore the R wave, which is present here. Sorry, Q wave, which is present here, and S wave. Let's see how much is this QRS complex height. This is one big box. So we know that is 0.5 millivolts. This is another big box, so that is another 0.5 millivolts. And 1, 2, 3, about small 3. So it is about 1.3 millivolts. Normal, yes, from 0.5 to up to 3 millivolts is normal. It depends where the probe was present. So if you are the doctor who's looking at the lead, you should know where the lead was attached, and according to that, you should know what should be the potential here. So that is done as well. So now we have talked about ECG, ECGs, paper, leads, potentials. What we'll do is let's close it today here. And next time, if you guys like, please speak with your MSAI representative, and we can do the pathologies and the cardiac axis. So before we close, I just want to give you one quick idea of the cardiac axis so that you can at least start using it. Look, cardiac axis is you need two leads to fully determine the axis. One is AVF normally, and the second is lead 2. Heart's normal axis is 59 degrees. That is very much in line with lead 2, which is 60 degrees. AVF is 90 degrees, and lead 1 is 0 degrees. Normally, minus 30 to 90, if the heart's axis sits in this range, then you say it is normal. If it deviates on the either side, then we have a problem. But the question is, how do you calculate the deviation? This is where, when I talked about the projection, that is important. So let's do this little exercise for this person. Let's put 0, that is lead 1, AVF, that is lead of AVF, and then 2, that is lead here. Now let's see what is the potential of the lead 2. The potential of the lead we thought was about 1.3, right? So about 1.3 is the potential in lead 2. Now how about the lead 1? What is the potential there? Almost 1 box up and 1 box down. So let's say 1.5, somewhere over here. That is the vector on lead 1. How about AVF? So AVF is almost very similar to lead 1. So it is also, let's say, till here. So now if you create a projection of these, you put them on a piece of paper and you project them, you would see that the line is almost coming in this area here. So this person actually has fine axis. However, if for some reason, let's say that his lead 2 was showing electrical activity that was negative, that means you go up and you put the vector like this. Now you put the projection here, and what quadrant have you entered? You have entered this quadrant. Let's say the lead AVF was positive. So lead AVF is showing here, lead 1 is showing here, so this would be the axis. So again, it's a big lecture in itself. I'll do the axis later on, but it is very simple to look at lead 2 and AVF and very quickly measure the axis or determine the axis even visually. And as soon as you determine the axis, you can actually see that if the patient has a right or left axis deviation, or also from this you can determine if they have myocardial infarction. So please talk with your MSI representative. If you like, we will do cardiac axis determination from this quadrant method that I just did in front of you, and pathologies later on. So guys, thank you very much. Next time when we'll do it, we'll make it more interactive. Bye for now.